Hello everyone. In this session, we will discuss Mycobacterium leprae, the causative agent of leprosy, also known as Hansen's disease. Leprosy is a chronic infectious disease that primarily affects the skin and peripheral nerves. The organism is a rod-shaped bacillus measuring approximately 0.3 to 0.5 micrometers in diameter. The term Hansen's disease is frequently used in examinations and clinical practice to reduce the social stigma associated with the word leprosy. Microbiology and growth characteristics. Mycobacterium leprae is an acid-fast bacillus, meaning it stains with acid-fast stain and not with gram stain, due to the presence of mycolic acid in its cell wall. It is the slowest-growing human bacterial pathogen. One of its most important biological features is its preference for cooler temperatures, around 30 degrees Celsius. This temperature preference explains why leprosy mainly affects cooler parts of the body, such as the skin, nose, ears, and peripheral nerves, while sparing warmer internal organs. Hosts and transmission. Humans are the primary host of Mycobacterium leprae. Armadillos are the only other significant natural reservoir. An infection has been associated with handling armadillos, particularly in certain regions. Transmission between humans requires prolonged close contact and occurs mainly through airborne droplets or nasal secretions from untreated lepromatous patients, who carry a high bacterial load. The disease is not highly contagious and typically develops after long-term exposure. Pathogenesis. The organism replicates intracellularly and primarily targets skin histiocytes, endothelial cells, and most importantly, Schwann cells of peripheral nerves. Invasion of Schwann cells is a unique and high-yield feature of Mycobacterium leprae. The mechanism of damage includes both direct bacterial replication and immune-mediated injury. The host cell-mediated immune response attacks infected nerves, leading to inflammation, demyelination, and eventually loss of sensation, which is the hallmark of the disease. Leprosy is best understood as an immune spectrum. The clinical form of the disease depends entirely on the strength of the host cell-mediated immunity. When immunity is strong, the infection is contained, resulting in tuberculoid leprosy. When immunity is weak or absent, the infection spreads widely, resulting in lepromatous leprosy. Intermediate borderline forms may exist and can progress toward either pole depending on immune status. Tuberculoid leprosy. Tuberculoid leprosy is characterized by strong cell-mediated immunity. Because of this strong immune response, very few acid-fast bacilli are seen in lesions, making it a possibacillary form. Histologically, granulomas with giant cells are formed as the body attempts to wall off the infection. Clinically, patients develop well-demarcated hypopigmented macules with significant sensory loss. The transmission risk is low. The lepromin skin test is positive, indicating that the immune system recognizes the antigen and mounts a response. Lepromatous leprosy. Lepromatous leprosy occurs in patients with poor or absent cell-mediated immunity. In this form, large numbers of organisms are present in skin lesions and nasal secretions, making it multibacillary and highly infectious. Histologically, granulomas are absent. Instead, tissues contain lipid-laden macrophages known as foam cells or virtuose cells packed with bacteria. The lepromin skin test is negative because the immune system fails to respond effectively to the antigen. Clinically, tuberculoid leprosy presents with one or few hypopigmented, well-demarcated lesions and minimal tissue destruction. In contrast, lepromatous leprosy presents with multiple, widespread nodular skin lesions and progressive tissue damage. Lepromatous disease may involve both skin and mucous membranes, and lesions are poorly defined and disseminated. Now that we have compared the clinical presentations of tuberculoid and lepromatous leprosy, let us consolidate the key differences in a structured manner. Tuberculoid leprosy is characterized by a low organism count, low infectivity, strong cell-mediated immunity, and a positive lepromin skin test. In contrast, lepromatous leprosy demonstrates a high organism count, high infectivity, weak or absent cell-mediated immunity, and a negative lepromin test. A very important rule to remember for examinations is that a high bacterial load corresponds to a negative lepromin test, whereas a low bacterial load corresponds to a positive lepromin test. This inverse relationship helps in rapid classification during Viva or MCQ-based exams. Now let us move to the clinical findings of leprosy. The incubation period of leprosy is long and averages several years, and the onset of disease is gradual. In tuberculoid leprosy, patients develop hypopigmented macular or plaque-like skin lesions. These lesions are well-defined and are associated with thickened superficial peripheral nerves. A very important feature is significant anesthesia within the skin lesions. In contrast, in lepromatous leprosy, multiple nodular skin lesions develop. These lesions are widespread and may eventually lead to the typical leonine facies, which gives the face a line-like appearance, due to thickening of the facial skin and loss of eyebrows. After initiation of therapy, patients with lepromatous leprosy may develop erythema nodosum leprosum, commonly known as ENL. This condition is interpreted as a sign that cell-mediated immunity is being restored. ENL is characterized by painful nodules, especially along the extensor surfaces such as the tibia and ulna. One very high-yield concept is understanding the mechanism of disfigurement. The disfiguring appearance of leprosy results from three major factors. First, skin anesthesia leads to repeated burns and trauma, which often become infected. Second, bone resorption leads to loss of features such as the nose and fingertips. Third, infiltration of skin and nerves results in thickening and folding of the skin. Patients with intermediate forms of the disease, known as borderline leprosy, may progress toward either tuberculoid or lepromatous extremes depending on their immune status. Diagnosis involves examination of samples from skin lesions or nasal scrapings. Acid-fast staining reveals red bacilli. In lepromatous cases, foam cells containing numerous acid-fast bacilli are commonly observed. A key point is that Mycobacterium leprae cannot be cultured on artificial media. Therefore, if asked which medium grows M. leprae, the correct answer is none. The lepromin skin test involves intradermal injection of inactivated Mycobacterium leprae and observing for induration after 48 hours. This test is not used for primary diagnosis. Instead, it helps classify the type of leprosy and assess the integrity of cell-mediated immunity. A positive test suggests tuberculoid disease, whereas a negative test suggests lepromatous disease. Treatment is based on multi-drug therapy. In possibacillary or tuberculoid cases, a 2-drug regimen of dapsone and rifampin is given for several months. In multibacillary or lepromatous cases, a 3-drug regimen of dapsone, rifampin, and clofazimine is used to prevent resistance and manage high bacterial load. Long-term adherence to therapy is essential for a complete cure and prevention of complications. Prevention includes isolation of untreated lepromatous patients until they become non-infectious. Chemoprophylaxis may be given to close contacts in certain settings. Currently, there is no specific vaccine available for leprosy. Thank you for watching.